Hello everyone, my name is Deborah Shuchuk and I'm an undergraduate psychology student at Concordia University. Today I'm going to be talking to you about the social and cognitive processes involved in racism in healthcare, specifically in Latin America. I will begin by explaining what racism is and why it is important to talk about it in the context of healthcare. Then we will dive into the first process, which is racial categorization, followed by stereotypes, group bias, and finally, social exclusion. Racism is a form of prejudice and discrimination against individuals based on their race or ethnicity. Racism exists across many settings, including healthcare, and can result in health disparities for marginalized individuals. To combat racism in healthcare, it is necessary to understand the mechanisms behind it. And while the issue of racism in healthcare is widely acknowledged, there is a noticeable gap in the literature concerning non-Western and non-English speaking populations. Race refers to the division of the human species into various groups based on inherent physical and social traits. Another term for this division is known as racial categorization. Some cultures base this categorization on ethnic background, while others categorize humans by phenotype. Phenotypic markers such as skin color function as distinguishing factors for social-cultural classifications, dictating how others perceive and treat individuals. The essentialist theory of race is a belief that race is a real entity that determines a person's dispositions and is characterized by clear, unalterable physical and psychological markers. In 2013, Chow et al. Investigated the role of racial essentialism in the process of racial categorization by conducting 5 separate studies with undergraduate students from the University of Illinois. Overall, the results support their hypothesis that racial essentialism is linked to a preference for utilizing racial categorization. Furthermore, this process of racialization happens regardless of people's identification with particular racial or ethnic groups. In Latin America, because having darker skin is associated with being indigenous, people may be categorized such, even if they do not identify as indigenous. Ortiz-Hernandez et al. Conducted a study examining the relationship between self-rated health and happiness and skin color among Mexican individuals. They found that people categorized as having light brown and dark brown skin reported lower levels of health and happiness than their white counterparts. This underscores the effect that racial categorization may have on an individual's perceived well-being. Racialization occurs when perceived physical differences are used to categorize people into groups. And once these categories have been created, people begin to develop stereotypes. A stereotype is a broad assumption about people based only on their membership in a group. From a social cognition viewpoint, stereotypes function as schema. This refers to unconscious mental categories created in people's minds to help them organize and make sense of the world around them, freeing up valuable mental resources for other tasks. In their scoping review, Hamed et al. Examined 213 articles about racism in healthcare that were written in English across national contexts, including the USA, UK, Canada, Australia, New Zealand, Israel, Sweden, France, Belgium, Spain, Finland, Brazil, Portugal, Germany, Slovakia, Ireland, Romania, Turkey, India, Malaysia, and South Africa. They found that healthcare workers across various cultures have a tendency to homogenize racialized minority groups. In other words, treating all members of the group as though they are the same. Additionally, healthcare staff often view racialized minority healthcare users as difficult and hold a range of negative stereotypes about them, such as that they are uneducated, unreliable, and less desirable patients. Similarly, Maina et al. Conducted a systematic review of implicit association tests given to healthcare providers, which were used to determine their implicit racial and ethnic bias. The results suggest that certain stereotypes such as noncompliance and reduced cooperativeness are associated with racialized minorities. These negative attitudes and stereotypes are usually unconscious. However, this still produces racism. Differences in phenotypes serve as markers for social categorization, defining social interactions and hierarchies by including or excluding individuals from certain groups. This can lead to what is known as group bias. Group bias is the tendency to favor members of your own group over others. And while individuals from socially dominant racial groups tend to exhibit a significant preference for their in-group, members of non-dominant groups typically do not show the same inclination. In Brazil, it was found that they even may prefer the out-group instead. Sacco et al. Studied the implicit and explicit racial preferences of Brazilian adolescents aged 6 to 12, who identified as white, Pardo, or Black. Pardo refers to mixed race. The findings across multiple measures demonstrated the widespread existence of racial bias in favor of majority groups. Moreover, in their scoping review, Hamed et al. Found that healthcare staff tend to favor majority groups over minority groups. This can have far-reaching consequences for members of the minority groups. When certain social groups are prevented from engaging fully in economic, social, political, and cultural spheres of society due to structural mechanisms, this is called social exclusion. People may face exclusion for many reasons, such as race, gender, and sexual orientation. Intersectionality occurs when individuals belong to more than one socially marginalized group, resulting in compounded discrimination. Samuel et al. Investigated the effect of social exclusion on universal health coverage in Latin America. They did this by conducting an in-depth analysis of 2 case studies, one in Guatemala and the other in Peru. The aim was to compare the challenges faced by socially excluded groups with an emphasis on indigenous populations in accessing universal health coverage. Their findings indicate that social exclusion limits access to healthcare through illegal charges for services officially covered by public health care programs, denials of service, lack of required medicines or equipment, cultural insensitivity, discrimination, and even abuse. Additionally, in both Western and non-Western contexts, Hamed et al. Found that racialized minority healthcare users share the perception of being dismissed and left out of the decision-making processes. These users also felt that they were not taken seriously when explaining their symptoms to healthcare staff. The aforementioned experiences of racism may lead racialized minority healthcare users to avoid seeking healthcare altogether, leading to even further exclusion. All these processes are interconnected, such that racial categorization contributes to people's stereotypes and biases, leading to social exclusion of members of racialized minority groups. This can have far-reaching consequences for members of the minority groups, especially those affected by intersectionality, as they may face discrimination, an inability to access proper care, and may even avoid seeking care due to the previous experiences of racism. This highlights the necessity of proper medical education and underscores the need for more research conducted by and on non-weird populations. Thank you so much for your time.